So it's 3 o'clock. Shall we start? So please, John King Lopez, give out the first speech.
Thank you very much. Good evening, good afternoon rather. A little ahead of my time here. It's really a pleasure to be here. Welcome you all to this refractive surgery session. And it's my honor to present on behalf of a large group of investigators that span throughout the whole world. Matthias Maus is in Cologne, Germany. Chandra Bala is in Sydney, Australia. Ramin Karamia is in Germany as well. And myself from Athens, Greece, and New York City, New York. I'll be discussing about an entity that is quite new in refractive surgery, and will try and do my best to describe it to you. So Wavelight Plus is a commercial name for this customized technology that uses ray tracing in order to determine automatically lower aberrations, myopia and astigmatism, because this was a myopic astigmatic LASIK study, as well as high order aberrations. It is a completely different refractive surgery entity than what you have been used till now. In essence, it uses a single device as a diagnostic device. So it's one box that obtains interferometry measurements, and from those measurements, it designs a three-dimensional virtual eye for each eye that it evaluates. So this really deviates from any other technology up until today that uses the standard Goldstern eye to extrapolate laser treatments. So we have this 3D model eye, and then it uses, we'll see it in our next slide, and obviously the purpose was to evaluate in this multi-center study a large number of patients who went to have myopic or myopic astigmatic LASIK. So these are the key criteria: under 9 diopters of myopia, up to 4 diopters of astigmatism, the standard exclusion criteria for pre-existing corneal disease, pregnancy test for the female patients, and in the methodology, the key thing was that the data provided by this technology, and this is an automated algorithm, were used by all surgeons, and I'll pause for a few seconds, unmodified. So whatever the device spit out, and excuse my French here, as the treatment as far as lower aberrations, myopia and astigmatism, higher aberrations, were actually set by the device, stepped on the pedal, delivered on the cornea. And this is new for laser refractive surgery, at least for me. Now, I mentioned before that, I'll go back to the slide, that this technology uses a single diagnostic device, and this is a configured Oculus Pentacam HR Wave AXL by the Alcon WaveLight team to use the 3 diagnoses that I mentioned before: interferometry, high resolution scientific imaging, as well as Hartmann-Shack wavefront analysis. Each one of these measurements are performed in multitude and are also checked for accuracy by the device itself. And that accuracy check is a go-to in order to extrapolate the data. And the device uses a 3D model eye that I described, and then 2000 ray traced from the scientific device to the anterior surface of the lens, and then 2000 rays theoretically traced from the retina surface based on the Hartmann-Shack wavefront data, all the way through the vitreous, through the crystalline lens of the patient, to the anterior surface of the lens. And fourth step, using a virtual representation of the lenticular system of the crystalline lens of the patient and the cornea, and what the potential tilt between these two optical entities have between them. So it does extrapolate these data into the treatment. These are the outcomes. I know nobody is impressed because laser vision correction today offers this type of outcomes. Very good approach of 20/20 vision postoperatively, even early on. Good correction of astigmatism. But the key thing here is that in looking at lines of vision gained, over 60% of the eyes, so over 2 out of 3 patients, gain at least 1 line of visual acuity when we compared pre-op best corrected visual acuity to post-op uncorrected, and over 30% of the eyes gain 2 lines of vision. And this is something new in laser refractive surgery. This is kind of what the display of the Sightmap, this is what it's called in Alcon WaveLight language, and I do consult for Alcon, so I do have financial interest in this presentation as far as a consultant. This is the change in MRSC. There was a subjective patient satisfaction survey. I personally don't spend much time assessing these. The other key thing is that aberrometry had a very subtle change, and this is another new for LASIK correction, especially when we're treating eyes over -3, even in the range of over -5. There was a very subtle increase in higher order aberrations, underlining the importance of correcting preemptively higher aberrations with this device. So as far as safety, this is a list of all the adverse reactions noted with these patients. We just had one incomplete flap in the group from Germany, and that patient was obviously excluded from the data. And in conclusion, and I have personally been very lucky to have been working with this technology since it was CE marked. This is the approval in the European Union. In 2019, we published on this in our center in Athens. Back in 2020, we've also employed this technology off-label outside the US to treat irregular eyes, and we published on this as well. But looking at this in naive, myopic astigmatic eyes, we have seen a new mode of customization that addresses lower aberrations in an automated way, so away from the manifest subjective refraction of patients, which has been the gold standard up till now. And it appears that along with correcting or attempting to correct higher order aberrations in lieu of coma, trifle, and spherical aberration, it does give us the ability to have patients gain lines of vision. In reality, in the real world, since 2019, we've changed the optotypes in our center to be able to look into the 25 visual acuity, which is something I have never, ever had to do in my life. So we have all the optotypes in our center in Athens now. 14 optotypes have been upgraded to be able to look at lines of vision that we never evaluated before. I want to thank my co-investigators in this study, and of course you for your attention. Thanks so much.
Thank you, John. So some questions?
So, there's an FDA study that's...
Let's record this.
Yeah. There is an FDA study that's gone on, and the data is being submitted, but this is a good post-market study in Europe. The concept of not needing to adjust because you could just plug it in and it iterates makes it very patient-specific, but there's always a surgeon factor to a nomogram that every surgeon's going to do something a little different. Have you any sense about that among the surgeons in the study?
You bring up a very good point that should include this group in a whole day session brainstorming. And I thank you for making this, Ron. Personally, for myself, and I'll deviate a little bit for your question to reach your question, this is a personal vindication of my work with customized ablations over the last 10 years. Because we have pursued this goal through topography-guided and TMR, adjusting the topography-suggested axis and amount of astigmatism in contrast to the standard subjective manifest refraction, through 10 devices, individual devices, and through a process that took us at least half hour for each eye. So this is now done automatically. I realize in coming to answer your question specifically that it takes quite a leap of faith for a surgeon, any one of you sitting right now here, to say, okay, I'm going to go through with this. And obviously there's a learning curve with this, like with anything. There's issues with accommodation, especially with younger patients, and we have discussed these among us. But I think we have found a way to take away that bias from the measurements. It has the ability to measure both in small pupil and mesopic pupil conditions. And there is now data on this device to offer you the security that what it suggests to do as a spherical equivalent treatment makes sense. But in essence, it's difficult for a surgeon to accept that they will go with the treatment completely, and I understand that. I personally think that it takes away the work of the team of 2 hours into a 20-minute diagnostics and 40 seconds of calculations with the algorithm to get the same level of outcomes in myopic LASIK.
You also need to have a minimal pupil size, right?
Correct. That
Which
is a restriction because
is it 5.5, 6?
it's 5.5, and it's an obvious restriction because a pivotal part in the recipe is the wavefront data. And if you have a pupil smaller than 5.5 millimeter, you're not looking into enough wavefront data to make your recipe work. Ideally, and this is a pearl outside the study, and this is not just a European study, this is a study from all over the world except the US. And I know the US study has similar preliminary data as well, kind of showing that this can work anywhere on the planet. But we have been working with using 1 drop of 0.5% tropicamide as the standard physiological state of the patient to be evaluated by this device and speed up the process.
Thank you, John.
Thank you.
Thank you. So next speaker is